Hello, my name is Sarah Zamastolova Schlothen-Christensen, and my project this semester was to investigate the impact of the COVID-19 pandemic on women, specifically relative to reproductive rights and wellness. I chose this project because experientially, anecdotally, it seemed to be that I was seeing this happen, but I was curious if the literature would bear it out. This research is needed because reproductive rights and wellness are integral to women's ability to self-actualize and impact so many aspects of a woman's life, not just her professional and financial future, but also her social reality and her health. COVID-19 has, in fact, restricted women's access to sexual and reproductive health care, and thereby made reproductive rights, or the exercise of reproductive rights, more tenuous, which in turn contributes to women's lives being more vulnerable. That, in and of itself, has made this research review valuable and indicates a need for further research moving forward in this area. Understanding how the pandemic has influenced women allows us not only to address disparities that have been exacerbated or developed during this time, but also to create a framework so that in the future, other crises don't have to have the same outcome. After reading the studies, I selected those that were most applicable, and I divided them into 5 main research categories for this. General wellness, which was exactly what it sounds like, kind of a review of overall care and legislation. Abortive access and experience, contraceptive access and utilization. Fertility, this area I chose since I was already dealing with the ability of women to prevent pregnancy or to terminate pregnancy. It seemed reasonable to also include the ability of women to facilitate pregnancy. And last but not least, specific care provision, which is things like mammography and cervical cancer screening. In the general wellness category, the research showed that infrastructural costs were largely responsible for exacerbating care disparities along already existing class and race lines. Some of this was because clinics were expected to provide personal protective equipment like masks and gloves more expansively than they had done in the past, but most of it was because of supply chain issues, which increased the costs of medical supplies as well as PPE, and policy changes, all of which forced clinics to reduce their hours or change their practices and increase their costs, especially those that they had to pass on to women or other patients. The protections for sexual and reproductive health and wellness were also just not primary considerations in the early stages of the pandemic. And that reality continued to influence future policy changes or decisions as time passed. In total, roughly 1 in 4 women experienced interruptions to their primary and preventative care. In the category of abortion, a number of new barriers to abortion developed during COVID-19. This could take the shape of things like travel restrictions between states, clinic closures and reduced hours, sheltering in place without a support system, social distancing policies, forcing especially younger women to access care without a support person available to them, lack of privacy, and so forth. In total, 13 states pronounced abortion an elective procedure, which obviously made it significantly more challenging for women to access. And of these, 8 states threatened criminal charges and fines to practitioners who continued, which made care even more tenuous and challenging to access. Abortion restrictions that were already in place, such as mandatory counseling and required visits in person, not only increased staff transmission of COVID-19, which then could lead to reduced hours and clinic closures, but also increased women's risk of contracting COVID-19 via unnecessary clinic visits. All of these inequalities were most noted along race and class lines. But it does bear out in the research that approximately 40% of cisgender women indicated changes to their reproductive choices, which suggests that a wider swath of the population was subject to a lot of these barriers as well. In the category of contraception, I noted that reproductive autonomy was most impacted, again, amongst marginalized populations. There was an increased economic insecurity in the first few years of the pandemic, which reduced women's interest in pregnancy, especially among women of color. But at the same time, over half of women were experiencing barriers to accessing contraceptive care. This is particularly noticeable in the fact that contraceptive visits declined, especially for tubal ligation, which declined by about 2/3, and by the fact that these contraceptive visit rates remain depressed. 1 in 4 practitioners temporarily closed their practices, and even postpartum contraception became more challenging to access. This is an area that's really important to this issue because contraceptive access and use is not only about being able to access any birth control. It's about being able to access the ideal form of birth control that will allow women to control their reproduction. And when women are forced to use a non-ideal form because that's what's available or just that's what they can access, their success rate is much lower. That can reduce, or that can result in obviously an increased number of unintended or undesired pregnancies, the burden of which largely falls on women. And as we've already seen, barriers to abortion were also significant. Within the fertility section, a really interesting phenomenon turns up, and that is that unlike other sectors of sexual and reproductive health, fertility medicine clinics worked with experts at the American Society for Reproductive Medicine to craft an intersectional approach. Their hope was that in doing this, they would provide universal guidance that would kind of make it a little bit easier, a little more predictable for practitioners, and as well as for patients to understand what was going to happen, and that it would reduce disparities. And it was incredibly functional. 1 in 3 women trying to conceive did delay or reduce their planned number of children because of the pandemic, especially women of color. And this is borne out through the reality that there was a decline in the birth rate amongst those women, but in total, there was actually a baby boom. And that baby boom was predominantly fueled by white college-educated women having a greater number of babies. So the ASRM worked with fertility clinics to reestablish care gradually, to prioritize sensitive situations. This could be, for example, cancer patients, and to mitigate clinic transmission of COVID-19. In doing this, they made the impacts here to women of color in particular less significant, or less significant in comparison to other sectors of sexual and reproductive health. And they also encouraged a lack of confusion amongst patients and staff, as well as a general higher level of confidence among the patients. In the last category, specific care provision, there were a lot of interruptions as well. Cervical cancer screening disruptions were expected to increase cancer rates by several dozen per 1 million women, resulting in a total of several thousand cervical cancer diagnoses at later stages. When you say it like that, it doesn't sound like a huge issue, but according to the National Institute of Health, just over 1 in 3 of those women will die. And those are lives that didn't have to be lost to this. In some cases, mammography actually declined by as much as 94%. And while rates of mammography did experience some rebounds, they didn't sustain that progress. And not every form of mammography actually fully rebounded. 1 in 3 women experienced delayed or canceled prenatal care. So obviously it was pretty significant across a variety of types of specific care. The good news is there are some solutions, and several of them were already implemented with some luck. So first of all, we can craft policies in advance of the next public health crisis that are more inclusive and that place these rights and these ideals at the forefront, including things like education campaigns on the importance of women's healthcare, so that those around women can prioritize this, can conceptualize it as something that influences the overall community health. Second, we can improve and expand telehealth access, something that we are already seeing occur. Clinics can begin to maintain stocks of PPE and stocks of medical supplies that are shelf stable, so that in future crises, sudden influx of need isn't going to impact their financial status or the cost to their patients quite as rapidly. We can expand Medicaid reimbursement for a variety of services so that women who are most affected, most vulnerable to things like increased cost or barriers of relative to their jobs or securing time off and transportation, childcare, et cetera, all of that can kind of be a little less likely to be an issue. We can also reduce some of those barriers by providing more transportation options that are federally funded. So those are also solutions. And last but not least, one of the big ones that occurred in abortion care was that postal delivery of abortifacients was first restricted and then made all but impossible. And we can reinstate postal delivery of abortifacients, re-legislate that so that it can be legal, which would eliminate a lot of barriers, such as things like mandatory counseling and wait sessions, and still allow women to access the care they need in an appropriate time frame. Women's health has been made more precarious by the pandemic, by the related public health policies, and this often exacerbated existing disparities along class and race lines. All of these rights influence women's ability to self-actualize, to access financial security, to experience positive health outcomes. So it's a very important thing for us to address. It also raises ethical questions. Is it ethical for our society to know this is happening in domains of healthcare that are exclusively for women, and not make efforts to address this, not make efforts to prevent it from happening in the future? And what does it say about our society that we undervalue women's healthcare to such an extent that in some areas it could drop by as much as 94%? One sociological theory that's really helpful to use to frame this issue is feminist theory, which falls under the umbrella of conflict theory. Feminist theorists like Charlotte Perkins Gilman recognize the importance of a woman having autonomy and realizing her full potential. In a situation where women's access to healthcare is inequitable and unpredictable, human rights are invariably violated and autonomy cannot be functionally attained. So that's it. Thank you for listening. And I look forward to seeing everybody else's projects.